Good morning. This will be our last class in this year, and next class would be in the starting. And the next class will be in the new year, and I don't know whether I will be taking these classes in the next year. So last class we have seen some benign bone tumors, out of which we have seen the most common one, exostosis or osteoclastoma. And in this class, we will see and learn something about giant cell tumor. It's a very fascinating tumor in that, though it's a benign most of the times, sometimes it becomes locally aggressive. And funny thing is, it has metastasis in lungs sometimes. Malignant or otherwise, it's a problem treating these patients. And there are very peculiar things associated with this tumor. And it is very, very important from the examination point of view also. It can be asked as a theory question, or if the case is there, definitely they can be kept as short case or slides or whatever. Even in discussion, this comes out quite often. So you should be knowing about giant cell tumor. Giant cell tumor usually occurs in the junction, epiphyseal-metaphyseal junction, mostly epiphysis, usually epiphysis. And there are some things associated with giant cell tumor which usually starts with E. So if you remember the letter E in English, which is a commonly used letter in English, most commonly used letter in English is E. So even here in GCT, the commonly used word or common features of GCT, they start with E. Location, epiphyseal, eccentric. So eccentric means it's not in the center. Usually it grows onto one side. And expanding. So another E. Expansile. So expansile, eccentric, and epiphyseal. So most common location would be epiphysis. This is a metaphysis and it's getting into the epiphysis. So all of you know that you should get a doubt that there is a growth plate separating the metaphysis and the epiphysis. And usually they will not cross into this. But how can the GCT does that with ease? Because this is very rare in children. That is also a very important point for you to remember. So once that growth is completed, then that barrier goes off. That growth plate between metaphysis and epiphysis is no longer there. There is no barrier. So this becomes one a single cavity. So that's when GCT strikes the bone. So though it starts here, it slowly comes into the epiphysis. It's more or less an epiphyseal growth. Epiphyseal. And as I told you, it is locally aggressive. What do you mean by locally aggressive? So even though it's not so malignant, it has a propensity to break the cortex and go into the soft tissues. That's what is meant by aggression here in this tumor. Locally aggressive and distant metastasis to lungs. Only lungs, and they are not malignant. Sometimes you may have a multicentric giant cell. So at the same time, you have a giant cell. We operated in 2 or 3 patients. The recent one which we did is lower in radius, and another was in sacrum. So it's a very rare multi-center. You don't call it as a secondary in other bones. It's a multi-centric. That means they arose simultaneously or one after the other. So one has nothing to do with the other growth. So that is multi-centric origin of GCT. Usually metastasized to lungs and locally malignant, locally aggressive, and epiphysis mostly. Coming to other things, all of you can see this is which bone? This is lower end femur. This is lower end femur, and this upper end tibia. This is the fibula. So common in and around the knees. See, ends of the long bones, as we have seen last time, because that's where the maximum growth. So that's where whenever there is some activity going on, there is a chance of it going wrong will be much higher. When there is no activity going anywhere, so nothing goes wrong. So you better do some wrong when doing something rather than not doing anything. Okay, so the same uh, applies here also. So the commonest, when you don't know the exact locations, you can say end of the long bones, lower end femur, upper end tibia, upper end humerus, something like that. Most often they are not, you will be right. Most of them are benign, as we have seen. So what do you mean by benign? They are encapsulated, another E, encapsulated. They're not breaking the cortex. Cortex is intact, and here, even here, in most of the tumors, this epiphyseal plate, this we call this as epiphyseal plate. This becomes very intact. They never breach this and come into the joint. They can breach the cortex and go into the soft tissues, but they will never breach this. So even the whole thing may be a hollow. Just by putting a finger, you can scoop out everything. But this is a tough epiphyseal plate, will be always intact. 1/3 are benign. You can have a rule of 1/3. 1/3 are benign, and 1/3 are locally malignant, and 1/3 are frankly malignant. So if you don't do a proper job, see, GCT is like a girl miffed. So they are very nice initially, but if you do some harm to them, then definitely they will take revenge. Similarly, even here, uh, even a normal 1/3 benign tumor, if you don't scoop out the whole and if you leave something behind, then it will become malignant locally. So the rule of 1/3, just remember this: 1/3 are benign, and 1/3 are locally malignant, and the other third are malignant, especially after ill advised attempts at surgery. So whenever you have a case, study it thoroughly and manage it properly. No half-hearted attempts in treating these fractures, these malignant tumors. Because if you do any half-hearted attempts at surgery, then you are putting the patient in much worse condition than you started one. So if you do a partial clearance here and leave most of it, then the one which you have left will become more aggressive than the original one. That you should remember. Coming to the clinical presentation, as we have already seen, most commonly seen after skeletal maturity. So once that barrier, that growth plate is fused, growth epiphysis is fused with the metaphysis, the growth is complete, then that growth plate is gone. Then GCT makes its presence. And 20 to 40 years. See, usually most of the epiphyses fuse around 2021. That's when the growth stops. So, if you want to grow tall, I think you should do what all you want to do, physical activity or good nutrition or whatever, before the epiphysis fuse. And you should not do some strenuous activities like weightlifting and all before the epiphysis is fused. Otherwise, the patient will be a short statured person. So somebody comes and asks you when is the best time to start doing strenuous exercises or weight lifting, then you should ask them to wait till epiphyses are fused. And as always, it's more common in the females, 2:1. And most often you see them in the long bones, especially ends. So whenever they are taking part in a joint, that's where they are more common, articular ends. And if it occurs in children, that is skeletally immature, then the location would be a metaphyseal one. So epiphyseal location is almost always common, and it is almost always in skeletally mature persons, and in very rare, less than 1% in skeletally immature persons. Then it can be a metaphyseal swelling. Otherwise, most often it is epiphyseal. Epiphyseal, eccentric, expansile, encapsulated. And one more E I will tell you as the class goes on. So, what are the clinical features? So, this is a hand. Can you believe this? This is a hand. This is the wrist joint, and this is the hand. So, what are the bones in the hand? Forearm. This is radius and this is ulna. So, GCT is quite common in the lower end of radius. So, this is a GCT lower end radius clinical presentation. So, patient did not present to us till it's late. As this swelling was growing and wrist joint became stiff, then he came very, very late. So, this is the appearance at his first presentation with us. So, you can all see the hand. So, this is looking grotesque. See how he could stay without coming to a doctor for so long. We don't understand. And pain and swelling will be obvious. So, such a huge swelling will have definitely some pain. And all the other signs of inflammation will be there. Local rise of temperature, redness, and such a huge tumor. You can see the vasculature, engorged veins. All these things are quite common anywhere, tumor anywhere in the body. When it is growing fast, then you will have a lot of vascular things, very visible engorged veins and increased vascular supply. Unless increased vascular supply is there, this cannot grow so fast. And it could be tender. And once when you are feeling it, you feel some crackling, that as if you are walking on eggshells. Have you ever walked on eggshells? If somebody accidentally breaks an egg or throws the eggshell on the floor, and if you happen to put your foot on it, you hear that typical, and you can feel that typical eggshell crackling. Similarly, whenever you feel a GCT, it is you can feel this eggshell crackling. That's one of the characteristic features of GCT. And one more E for you. So, epiphyseal, eccentric, expansile, encapsulated, and eggshell crackling. I think you have 5. If you know these 5, I think you can write an essay. Okay. Other gaps you can fill, and you can present your essay question. So, it can present as a pathological fracture. Such a huge swelling eating away the bone becomes very, very weak, and a small trauma can result in a pathological fracture. And a pathological fracture is one which occurs in an abnormal bone. So once the bone is eaten away by this tumor, then it's very easy for anyone to break the bone, or as trivial trauma can result in a fracture. So that's called a pathological fracture. Sometimes pathological fracture may be the presenting sign. So patient comes to you with pain and say, suddenly I hit something, my pain is severe. Then once you take an X-ray, you can see bone eaten away and there is a break, fracture. So normally just by hitting a table or a chair with your hand will not result in any fracture. But when the bone is abnormal, when the bone is weakened by infection or by tumor, it's very easy for you to break it. So you can get a pathological fracture there, and there will be muscle atrophy. Imagine a hand or a forearm like this, and when the bone is growing, where will be the muscles be? And muscles will be atrophied, because patient may not be able to do anything with that hand because it's painful and swollen and joint is stiff. So patient is not doing anything with the muscles. So muscles will become disused atrophy. So muscles will go into what is known as disused atrophy. That's why they say you need to exercise your muscles as well as your brain. So whatever little brain God has given us, if you don't exercise, then you are going to lose your mental faculties. Okay, so you need to exercise them constantly. So muscle atrophy, and sometimes there may be joint effusion, but you can't miss this. Somebody, if they miss this, and there is medicine is not for them. Okay, so these are some of the presenting features of GCT. That depends on the anatomical location. It could be a lower end femur or apparent tibia near the knee joint, or it could be a lower end radius with a picture like this, or it could be an upper end humerus, or sometimes some abnormal locations like vertebral bodies. Vertebrae also can have these GCTs. We call them GCT. GCT is giant cell tumor. Other name for that is osteoclastoma. Osteoclastoma. So what are the routine investigations? Routine investigations like blood investigations are a must. CT, BT. Whenever you want to put your knife, I think you should better get this CT and BT, clotting time and bleeding time. So it's a minimum. You should know what is the status of the patient as far as that bleeding diathesis are concerned. So they give us a basic idea whether the patient has any problems with their bleeding or clotting times. And other things are quite common, hemoglobin and all, liver function tests, and how other organs are responding. And you should know before you put your knife. And then radiographs. Radiographs are your local area. See, this is elbow joint here. This is the lower end humerus. See, you can see a swelling in the epiphysis, and you can see the swelling which is eccentric and expanding. You can see all those epiphyseal, expanding, eccentric. Eccentric means to one side. So this is the center of the bone, but this is to one side. And expanding. So the bone has ballooned out lesion and epiphysis. And encapsulated. You can see capsule inside. And if you touch eggshell crackling, so the same one here, it's a CT with 3D reconstruction. So you can see that bone, and this epiphyseal plate is intact. Can you see it here? Down. So epiphyseal plate will be intact. The bone is destroyed here, but epiphysis is intact, and the cortex is gone here. It's ballooned up, eccentric, expanded. Okay. So I was telling you about GCT occurring in a vertebral body. So here is a vertebra. This is the anterior side. This is posterior. These are the posterior elements. We call them posterior elements. This is the body of the vertebra. and here you can see a lesion. This is GCT, and here this is a knee joint, and GCT from the proximal fibula. Head of the fibula, the whole of the head of the fibula is one bony mass. Here you can see. Okay, so this is a GCT of proximal fibula. So if you take a X-ray of the local area, you can clearly see, and a chest X-ray is a must to see whether any pulmonary mats are there. Unless you see a chest X-ray or a CT, pulmonary CT chest, then you may not be able to see the pulmonary metastasis in GCT. And sometimes an MRI is a must see to see the medullary extent of a tumor. So whenever there is a bone tumor, after the X-rays, it is always prudent to have an MRI done of the local area to know the extent of the tumor inside the medullary cavity. So X-ray may or may not show the extent of the tumor. So if you are planning a treatment option, so you need to know the extent of the tumor. So if the tumor is up to here, if you do surgery here and get away, you are not going to do good to the patient. So after surgery, as we have already seen, this becomes more malignant. If your surgery is not adequate, then even a simple thing will become a complicated one. So you should know the extent of the tumor, and for that you need to have an MRI. And any bone tumor, or for that matter any tumor anywhere in the body, what is the gold standard? Biopsy. So the history may tell you, or the X-ray, an X-ray looking like this definitely will give you the diagnosis. A CT with the 3D reconstruction will definitely tell you that this could be a GCT, but nothing to beat biopsy. Biopsy, and once you see the cells under microscope, histopathological examination is a must. And that biopsy could be an incisional biopsy. You can incise the bone and go inside and get the material for biopsy, or sometimes a case like this, upper end fibula. Upper end fibula can be sacrificed. So take out the upper end fibula even before you do biopsy. Take out this and send it for excision after excision biopsy. That is called excisional biopsy. Once you send the whole bone for biopsy, then if it comes back as GCT, then you are fine. So you must have already done MRI and you have known the extent of the disease, and then you have done treatment. With one stroke, you have done biopsy and you have done the treatment as well. But you will not be lucky in all cases. So if it occurs only at the upper end of the fibula, I think this is the treatment of choice. But if it occurs somewhere else, like lower end femur or upper end tibia, you can't take out the whole bone. So the whole joint is at stake there. So you need to reconstruct the joint or something else. So this excisional biopsy is applicable to only few areas where there will be the bones are expendable. Expendable means that even if you remove that, the heavens are not going to fall. If you don't have upper end fibula, no problem. But if you don't have lower end fibula, lower end fibula is much more important than upper end fibula, because lower end fibula is otherwise known as lateral malleolus, gives a lateral support to the ankle joint. Very, very important joint. And if you take it out, the whole fibula, if you take it out, then the both joints, that means the ankle joint will not be stable. So you decide when to do incisional biopsy or when to do excisional biopsy. So this is one of the treatment options as well as investigation, both excisional biopsy, especially if it is upper end fibula. Previously, we have talked that this is an expansile lesion. Expansile lesion. So this is a tibia, and this is the tumor. can see osteolytic lesion, because this bone appears normal. This bone appears normal, but here you can see some trabeculations. See, these are walls calcified like. Okay, so if you touch them and press them, then you will feel that eggshell crackling. So initially you will have a picture like this, and later on, with uh, extent of the tumor all around, then the picture may be like this. There is a cavity with a soft tissue inside, and sometimes this epiphyseal plate, it's thinned out. It usually is intact. So this is a GCT in the upper end of the tibia, and it is to one side. See, it's not completely in the center, it is towards the lateral side. Why do you say it is lateral side? Because what is this? This is fibula. Fibula is on the lateral side of the tibia. So lateral bone in the leg is fibula. So this is onto the lateral aspect. So starting from the midline, the whole lateral condyle of tibia is involved in the disease process. So this is GCT, upper end tibia. And you can see GCT in the lower end of the femur. So can you see it here like this? So this is a normal bone, femur. This is the medial condyle. This is the lateral condyle. And what is this shadow? This shadow, sclerotic shadow, is the patella. So patella you can see in the lateral views, but in AP views, it is superimposed over the distal femur. So this is the upper end of the tibia. This is the fibula. This is the lesion. See, from center it is extending on to the lateral side. And here you have, there is no new bone formation. That means purely osteolytic. There is no osteoblastic or new bone formation. If there is a new bone formation, you could see a new bone being formed. There is some sclerosis, but there is no sclerosis here. It's only osteolysis. So this is all dark shadow. So osteolytic. That's what no reactive sclerosis, and reaches up to the articular surface. It comes and lies till the joint, but it usually won't break this epiphyseal plate and comes into the joint. And eccentric location. See, you can clearly see it here. So this is the anterior surface and it is going beyond. Can you see it here? So this is antero. This in lateral view you can see that it is anteriorly situated, and in the AP view you can see that this is lateral. So anterolateral swelling. So clinically, if you see, there will be a swelling in the knee joint in the lower end of the femur, situated on the anterolateral aspect. If you get an X-ray done, so this will be the radiological picture. If that becomes more aggressive, the X-ray quality may not be good, but I just want you guys to have a look here what happened. Okay, so you can see the swelling from here till here. Okay, and there is a break in the cortex. So there is a pathological fracture. So breaking of femur is not easy. Femur is the strongest bone in the body, and it needs a lot of violence for someone to break a femur. But here the bone is very weak because of the pathological process. The tumor has weakened and it led to a fracture. Here you can see this is the proximal fragment and this is the distal fragment. A supracondylar fracture of the femur was a result of a pathological process. This is a GCT. So patient presented to us like this. So the history of trauma was insignificant. Just patient while walking, he fell on at home, and usually it doesn't result unless the bones are very, very weak. unless they are around 80-year-old, when age-related osteoporosis will be there. But here, patient is not so old, then you should have a suspicion that it could be a pathological fracture. So once we have taken an X-ray, so this was the appearance. So this GCT lower end femur presented as a pathological fracture. So the same thing in the scan. So this is a break here, cortical break. You can see this is the femur, outlines of the femur. This is the patella, and here you can clearly see break in the cortex, and we can see the tumor extending into the soft tissues. So this is the advantage of having a scan. X-ray may not completely show. So this is the X-ray radiological findings. You think that there is a thin rim of cortex still present, but once you get a scan, you know for sure that there is a cortical break definitely, and there is no cortex as it is. And another example of common location for GCT, this is a typical one. Distal end radius. All of you know that this is a wrist joint comprising of distal end of radius, and this is distal end of ulna. And these are all the carpal bones. All of you know that scaphoid, lunate. You know that, no? Proximal row of carpal bones, distal row of carpal bones from lateral to medial. So the scaphoid and lunate, they are in touch with the distal end of the radius. So this is the articular plate here, you can see. And you can see cortex is thinned out and there is a ballooning. That means expansile lesion, eccentric lesion, epiphyseal, and you can see a cortex encapsulated. You can see the normal bone beyond the tumor. So the tumor is up to here. It has a capsule. That means encapsulated. So if you touch it, you can feel the eggshell crackling. So this is the scan appearance. You can see there is a cortical break here. And this is the extent of the tumor. So there are T1, T2 images. We'll be discussing those things when we discuss MRI. So this is how we proceed in the investigations. First, you examine the patient. While examining, take the history and the clinical examination, then the radiological examination, then you go for the scans. So unless you have everything, you don't put your knife, at least for incisional biopsy or for excision biopsy. Biopsy always. Any tumor, anywhere, the gold standard is biopsy. And there are some rules when you want to do a biopsy. So sometimes you may have to incise, you give an incision and do the biopsy. But nowadays, the oncology, ortho-oncology, the rules say that whoever is planning to do the definitive treatment should do the biopsy. Previously, anybody could do the biopsy, and once the biopsy report comes, then they were sent to the centers where these oncology surgeries are being up to. So not everybody is having all the facilities to do these oncological procedures. But now, because the incision which you are going to use for a biopsy should be placed in such a way that the incision which they are doing it for the definitive procedure, this should be compatible with that. So you need not, you should not do half-hearted job. You do the biopsy, send the patient to higher centers. That's no longer valid. So if you diagnose a bone tumor and if you are capable of doing it and if you have all the facilities in your center, then only do the biopsy and undertake the definitive treatment of the patient. If your center is ill equipped, or you don't have any exposure in doing this onco surgery, then for God's sake don't do biopsy with your ill advised incisions and send the patient to higher centers. So the incision also should be very well placed, and it can be extended when you are doing a definitive procedure. So you need not cut, because once you operate, you are seeding. That means the tumor has a propensity to, once you are cutting a plane, then the planes which are not infected before by the tumor cells will be exposed to the tumor cells, and tumor may spread. So you should think twice before incising. So you should know all these things. And one more thing is, whenever you are doing biopsy, the material should be uh, adequate to help the pathologist to arrive at the definitive diagnosis. It's not enough if this much of tumor is there. You just take just a pinch from somewhere here and send it and wait for his opinion. It will be difficult for him. So unless a larger amount of specimen should be sent for them to make an adequate diagnosis. And you should always send the history and the clinical features and the X-ray films. Unless all these things are there with the radiologist, pathologist, it will be very, very difficult for them to give a definitive opinion after biopsy. So these are some of the things which you should keep in mind whenever you are going to take the biopsy. So here we were doing a case, and this is how we open the tumor, and this is how the tumor looks from inside. See, the opening should be adequate. It should be so adequate that you should be able to take out the whole diseased material. So to make it more interesting for you, it's not enough if I just tell you some theory and go away. Those theory you can get in your textbook. If you are careful, you can get that in the textbook, and it will be easy for you to read. But if you show some practical things which we have done, then it will be very interesting for you. So we made a window like this, and we scooped out the whole thing. So these are called bone levers. See, these are called retractors. So they retract the soft tissue away from the bone. And you have so many instruments which we tell you before your exams and all, we'll show you. So unless you retract, then it will be difficult to work with. So these are the retractors. So this is the material which we have scooped out of that. So once we scoop it out, we spread it on the a gauze piece, and by looking at it, definitely you can make a diagnosis. If there is a lot of hemorrhagic field, see, these dark ones are the hemorrhages inside the neck, tumor necrosis and hemorrhages. So if they are more, that indicates it's more malignant. So even before you send it for histopathological examination, you can have an idea about the aggressiveness of the tumor. If the whole tumor is a necrotic or hemorrhagic mass, the more the necrosis, the more the hemorrhage, the more chances that it is malignant, more malignant. So by looking at the specimen itself, with some experience, if you're doing 3, 4, 5, 6, 7 some cases, then you gain this experience, and just by looking at the specimen you can have an idea even before the biopsy. So if the necrosis is more, if the hemorrhages are more, then the mitotic figures will be more. So anisocytosis, all these things, atypical appearances, all these things which indicate that it is more malignant can be easily made up even with our naked eye once you are doing and scooping out the tumor. So coming to the histology, this is a typical GCT slide wherein you find these giant cells. So there are several types of giant cells, most of you know, and this is a osteoclastic giant cell. So that's why it's called a osteoclastoma. And there will be some mononuclear cells interspersed with these giant cells, and you have this tumor. Whenever you have a tumor, you need to have this vascular stroma. So vascular stroma, giant cells, mononuclear cells, they indicate that it is GCT. And here the stromal cells look like fibroblasts. The stroma, which is, and this is the GCT, and they are vascularized spaces, stroma. Okay, fibrous fibroblasts like stromal cells, giant cells, and vascular stroma. So this indicates GCT. So coming to the differential diagnosis, as I told you in the last class itself, all these things will tell you that this is an osteolytic lesion. So you need to enumerate what are all the positive findings and what are the negative findings. What are all the positive findings for you to say that this is GCT, and what are all the negative findings to say that this is not GCT. So you need to know some conditions which can mimic GCT. So any osteolytic lesion anywhere in the body. So these are the conditions which should be thought of. So it should fit in one of these conditions. So all of you should know these 8 or 9 conditions. These are very, very important. Whenever you see an osteolytic lesion anywhere in the body, in the bones, then it could be one of these things. Coming from above, fibrous dysplasia. So for now, just remember what these are things. Then we can discuss one by one in later classes. It could be a fibrous dysplasia or fibrous cortical defect, or it could be an enchondroma or eosinophilic granuloma. So all these, as I keep telling you, they have a osteolytic appearance, and there may be a non-ossifying fibroma. Non-ossifying fibroma. The name itself tells you that it contains fibroblasts which are non-ossified. That means there is no newborn formation, fibroblast. So it's a soft osteolytic lesion. Osteoblastoma. Osteoblastoma is one of the differential diagnoses. Most common is metastasis or myeloma. So metastasis are the most common bone tumors. That's what they say for entrance. So if you are listening to our classes, in between you will have these nuggets. I think most of you are very much fond of these KFC nuggets and all. So these nuggets you get. So most common bone tumor is metastasis. Metastasis, the primary being anywhere. Primary may be in the breast, primary may be in the lung, primary may be in the prostate. So all these things have their secondaries in the bones. Or myeloma. Myeloma is multiple myeloma. So it affects multiple bones, and there is osteolytic lesion. So they are all characteristic. But once you have an osteolytic lesion, all these things you need to tick out that this is not fibrous dysplasia, because these are the positive findings to say that this is GCT, and these are the negative findings to say that this is not fibrous dysplasia, not enchondroma, non-ossifying fibroma. Like that, you need to exclude. Then the commonest clinical entity which mimics GCT is aneurysmal bone cyst, otherwise known as ABC. This ABC typically looks like GCT. In most cases, they mistake ABC for GCT. But aneurysmal bone cyst is very, very benign when compared with GCT. So you should not make that mistake. And biopsy will definitely tell you that what it is. But to do, even before you do the biopsy, you need to know that there are other things which can give a similar clinical radiological appearance. After bone cyst, there is another one called a simple bone cyst. This is aneurysmal bone cyst. Another one is simple bone cyst. Then you have this hyperparathyroidism. All of you know that parathormone is secreted in the body, and it is concerned. It concerns with the calcium metabolism. So whenever there is a serum calcium comes down, then this hormone brings it the serum calcium levels to normal. How it does? It brings calcium from the bank. What is the bank for calcium? Bones. So whenever there is hyperparathyroidism, bones will become osteolytic. Then it becomes there may be some bleeding there, and there is a tender, painful masses on the bones, and they are spoken to as brown tumors. They are brown in appearance, and they are very tender, painful, osteolytic, and that is because of the parathormone, increased parathormone. Sometimes infections can mimic GCT. Infection or infarction. Infarction means whenever the blood vessel supplying to that part of the bone is blocked, then that part of the bone becomes necrotic. That means there is no blood supply. Then there will be some changes in the bone, which may mimic GCT. And last one is chondromyxoma or chondromyxoid fibroma. So these are some clinical entities. All of you should know that just by looking at an X-ray or something like that, you are not supposed to make a diagnosis of GCT till the biopsy report is on your table. Okay. So these are some of the. One second. Hello. Hello. Yeah, 10 minutes. Class long. Class long, 10 minutes. Yeah. So this is college authorities. So I need to take the call. Sorry. So these are some of the clinical conditions which can mimic GCT. So this diagram, if you can look, you can have fibrous dysplasia here. So enchondroma, non-ossifying fibroma, simple bone cyst. This is aneurysmal bone cyst. This is also eccentric osteolytic lesion. This is enchondroma in the middle of the bone. Okay. And chondromyxoid fibroma. This is chondromyxoid fibroma. And this is the metastasis. Metastasis is very, very painful. So you should never miss a metastasis. So these are some of the differential diagnosis of GCT. Coming to the treatment, you should plan your treatment meticulously. Unless you have all the relevant data, you should not venture to treat that patient. Suppose you have a case like this. So this is a tumor in the lower end femur. All of you can see this is the femur, lower end femur. And this is the tumor. And there is a break in the cortex. The tumor has extended itself into the posterior aspect of the knee joint. So this is up to here, knee will be there. So the radiology, you can see expansile, extending, eccentric lesion, and there is a pathological fracture as well. So this looks like this, and this is the microphotograph. And these are all the drawings from Nutter. Nutter is a great man. Unfortunately, he died recently, and his illustrations made anatomy very, very easy for all of us to understand. And most of the illustrations in most of our textbooks, especially those Cunningham volumes, which we have studied during our anatomy days, and even today, anatomic atlas by Nutter is a must for every doctor. He makes it very easy for you to just visualize his simple diagrams. They are 3D. It's as if you are looking at the specimen. So because these tumors have a high potential for local recurrence. So you think you have done a good job. The picture we have shown that upper end tibia, we made a hole and took out everything and filled that hole with bone graft and bone cement and all. And I think it has been over 15 years. So this is every January. In every January, the patient comes and visits me with her latest set of X-rays, and I compare all the x-rays and I examine the patient clinically. I see for any swelling, any tenderness, any joint dysfunction, and I compare the x-rays to see whether the tumor has recurred or not. And I am very lucky, and the patient is very lucky that that didn't recur in these 15 years. So recurrence rates are very high in these GCTs. So you should be very careful, and your treatment should be adequate. Just like you escape something and you are afraid of bleeding, you stop the surgery in the middle, you are doing a disservice to the patient. Unless you are adequately trained and your center has all the things, then don't attempt to treat these patients. Then as I told you, adequate removal, the whole tumor. See, if this case comes to you, you need to take up to, you make a hole and take out the whole thing and fill this cavity with something so that it will not collapse and patient will have a functional knee joint. So how do you do that? We'll see later. But here, while taking this out, you need to take out the whole thing inside, which is there inside, has to be scraped down. Once you scrape out everything, then you wash this cavity with liquid nitrogen or phenol solution. So to kill these residual cells of osteoclastoma or GCT, once you take out the whole tumor, this becomes a shell. So it has only walls. This epiphyseal plate will be there intact, and this cortex may be intact or may not be. This cortex is not intact. So you pack this cavity with liquid nitrogen or phenol solutions so that all the remaining residual tumor cells are killed. Unless you do that, your clearance is not adequate and there is a chance for local recurrence. So whenever you plan to operate on these, then you should know what type of resection and how far I should cut, or whether I should take out the bone or not, or I should take out a part of the bone or the whole bone. If I want to take the whole bone, so how to reconstruct? There is no point taking out a lower end radius without having a plan for reconstruction of the wrist joint. Without wrist, the whole upper limb will be a waste. You cannot function without a wrist. So if there is a tumor in the lower end of the radius, you take out the tumor. Or sometimes if it is more malignant, take out the whole lower end of radius. You can reconstruct it by other means. So you need to plan this adequately even before you plan for surgery. So you need to take type of resection into consideration and the use of adjuvant therapy. Nowadays, the oncology has developed like anything. So now you offer them several modes of treatment. Even if you operate, before surgery you can go in for chemotherapy, and after surgery you can go in for radiotherapy. These are all the adjuvants. The main therapy is surgery. But you are using your chemotherapeutic drugs and your radiotherapy to assist you, and they are helping you. That is called the adjuvant therapy. So once the tumor load is reduced by means of your chemotherapy, then your surgery will be easy. Or once radiotherapy is undertaken before surgery, then the vascularity of the tumor comes down. Then you can operate. Then you can put him on chemotherapy. So it's not that only one type of treatment is being given. Nowadays we are combining radiotherapy with chemotherapy and surgery. So we are offering like a basket of goodies. So to say. So it's not only radiotherapy now, or it's not only chemo, surgery. It's a combination of these things. That's called adjuvant therapy. And if there is a cavity inside, especially for orthopedics in the GCT, then what is the material you should use to fill this gap? See, this is a lower end tibia. Most of you can make out that this is a ankle joint. So this is the fibula, this is the tibia, and this is the talus. This is the ankle joint. So there is a tumor here, and they have taken out the tumor, and the resultant cavity is filled with what is known as a bone cement. Instead of Rasi cement or Nagarjuna cement, we have bone cement, that is methyl methacrylate. So that methyl methacrylate, we filled it inside the cavity. It gives the rigidity and it gives the stability for the patient to walk. So this is as good as a bone inside. Okay. So this can give the patient a functioning joint. Coming to the types of resection, this is for your easy understanding. So, suppose this is taken from say a general surgery. The bone is a innocent bystander here. Okay, so the lesion is here. Then intralesional resection, that is the minimal one. That means that's called a debulking. The tumor mass is reduced in volume. That is intralesional. That means inside this is the lesion, and you are doing surgery inside to reduce the tumor mass. That is intralesional resection. If you do, what do you mean by a marginal resection? So apart from the lesion, a bit of normal tissue is being taken. That is a marginal resection. A wide resection is even more of normal bone is taken. That is wide resection. Wide resection is beyond margin. Beyond a radical resection, the whole limb is taken out. The more malignant the tumor, the more radical is the surgery. Starting from intralesional, which is the minimal, minor one. Only you just deal with the tumor. You don't do anything to the normal things. But marginal is beyond that. The whole tumor is taken out. Wide resection is a bit of normal, that is a collateral damage. So this tissue has nothing to do with the tumor, but because this is malignant, you have a suspicion that there could be some seepage. Then you do a wide resection. Radical resection means the whole limb is gone. So these are some of the terms which you need to know. Coming to the previous example, so what are the mode of treatment? So for this, what do you do? Excisional biopsy. So you cut up to here. You do an MRI, you can see the extension. Usually, if you cut up to here, the major thing which you should be aware of while doing this surgery is there is one structure which comes out like this and like this. That is lateral popliteal nerve or common peroneal nerves. From the posterior aspect, it comes laterally and into the anterior compartment, winds round the neck of the fibula. So whenever you are operating in and around this area, you should identify the nerve, isolate the nerve, and keep it away, then cut the bone. If you cut the nerve also along with the bone, then you are gone. So patient will have complications, and that comes as medical negligence. So this is GCT, upper end fibula. You excise that, you are done with it. So this is what we have done here. See, this is the GCT upper end fibula. This is the scan. We could see it is confined up to here. This is the surgical picture. We made a opening there and we cut it and we opened this. See, this is the tumor, eccentric, and this is the post-operative picture. So now the whole gamut of all the patient is in front of you. So this was say around 10-15 years ago. But now once you can have the electronic records with you, so you can see preoperative X-ray, preoperative scan, and peroperative picture. And this is the specimen cut into two halves, and you can see inside even before you send it to histopathological examination to get the biopsy report. And this is the extent postoperatively which we have uh, cut the upper end of the fibula. See this preoperative, postoperative. Adjuvant, this is what we said, other modalities. So here, apart from other modalities, we use liquid nitrogen, phenol or PMMA, that is bone cement. How do you take bone graft? So sometimes you have to fill the uh, cavity with bone grafts. So this is how usually we take bone graft. So this is iliac crest, all of you know. So this is inner cortex, the other one is the outer cortex, this is the superior cortex. So if you take a bit like this is having three cortices. So one is inside, one is superior, and one is the outside. So this is very strong. So it can substitute a bone. It won't crumple. The cortex, and this is the cancellous piece. So this is worth its weight in gold actually. Okay, this is how we take, but only in exceptional circumstances we do this extensive bone graft. Nowadays we have cadaver bone grafts, and bone banks are available, or bone substitutes are available. So in very rare cases only we do. Why don't we do this more often? Because if you do like this, then all the muscles which are attached here, there may be a scope for some herniation. So when there is a gap here, the muscles and intestinal are, so the intestine is a peculiar thing. So whenever there is an opening, it want to explore that opening. Sometimes you unnecessarily have these hernias coming out, and sometimes they may lead to some emergency. So once that hernia comes out and it cannot go back, then obstruction of the hernia, that is gangrene of the bowel, so many complications. And if it were to be a female, then aesthetically also a surgical scar there, and there may be some deformity if you take extensive. So all these things made us not to do this, but to show you how we can take a beautiful graft from the iliac crest. This is a tricortical graft which is very, very solid, very, very strong. Okay, that is a bone graft. Auto or allograft. Auto, donor is the patient, and allo, somebody else will give. So if the patient is a pediatric patient and he needs bone graft, who is the best source? Who is the best source? Mother of course. So coming to the PMMA, bone cement. So we get one liquid, one powder. So monomer and polymer. We mix and make a paste. So all orthopedic surgeons can make a good dough. So we can make rotis very easily. So if you practice making dough and rotis at home, I think mixing this bone cement comes easily to us. And once you mix this and you keep this inside the bone, and that gives stability. So this is a tumor bone graft which we have harvested from the, see, you take out from here, you take out, and this is to show you how much bone graft we can take. And we have filled that previous cavity. I think if you remember that cavity which we made in the bone, we filled the whole cavity with this bone graft. So this is the bone which is involved. We made an opening. Another case, we made an opening, scooped out the whole thing. This is a curette with which we are taking out the. So this is a femur, upper end femur. This is the greater trochanter, and we made opening into this, took out the whole thing, and put that graft here. So give stability. Once that stabilizes, and the tumor is not recurring, then that becomes as normal as original ones. So here, this is another clinical case. I just want to show you what all we did. And this is the lady I was telling you about. And the patient had a GCT in the lateral condyle. So the whole condyle is involved, but the lateral side it is more. And we scooped out the whole thing. We scooped out the whole thing and filled up with bone graft. Bone graft. And sometimes, if you are not sure that this bone graft is stable enough, you can take a part of fibula, cut a part of fibula. Middle third of the fibula is expendable, even the upper third. But usually we take out, if it is enough, we take out a middle third of the fibula and put it like a strut. So it gives us a mechanical leverage, mechanical advantage, and mechanical scaffold like, and fill the whole cavity with bone graft like this. So this is around after 2 years, more than 2 years of post-operative follow. So this is looks normal. So we look for this appearance. If it is there somewhere, that means there is a recurrence. So this is lower end of the radius. Lower end of the radius, scooped out and filled with bone graft. So this is the bone graft, appearance of bone graft immediately after the surgery. So this is a sclerotic mass, and over a period of time, this will get incorporated. There is something called a creeping substitution. That means the blood vessels will grow into the graft, and the whole graft will become absorbed, and it becomes a normal bone here. This is another example of upper end femur. Now this is the lesion, and it is being filled with bone graft. This is a scan. These are the X-rays. This is a scan report. And here lower end radius, all of you can make out. Lower end radius. We do another procedure here. This is very important for you to know, that we excise. Sometimes if it is very extensive and it is gone into the soft tissues, there is no point leaving it here and keeping bone grafts, because already this cortex has been breached and it has gone into the soft tissues. The whole soft tissues are being, and there is a pressure effect over the ulna. Even this ulna you can see, is it not? It's being pressed by this tumor. So there is no point keeping this tumor. So we excised this up to here. So, but I told you, wrist joint is a very important joint. You need to reconstruct. So this is the reconstruction which we have done with fibula from the opposite side. The patient can donate fibula sometimes, usually 90% of the patient, or if the patient is an youngster, then maybe mother's fibula can be put. This is the fibula which we have modified and as lower end of the radius. So fibula is coming and sitting in place of radius. So up to here we have cut, and we put that bone here and put a plate connecting these two. So this is the plate which connects. This is the graft. This is the fibular graft, upper end of the fibula, and this is the original radius. We fix that, and we osteotomize the ulna to gain the height. So you need to reconstruct the joint. There is no point if the joint is disorganized. If there is no surgery, then surgery is a waste. So once we do that and we fix those two, inferior radio-ulnar joint is also taken care with this screw. And this bone graft is attached to the donor, the host, this host bone with the plate. So radius, lower end radius is being reconstructed with a fibula. This is a upper end humerus, GCT of the upper end of the humerus. So there is a fracture here. So you can't leave it like that. So we took out and put a plate and fixed that and fixed it with bone grafts inside. This is another method called resection arthrodesis. The name itself indicates resection means you are resecting a part of the affected bone. Arthrodesis is a procedure where the joint is fused. So this is a functioning knee joint. And here you have a tumor in the upper end of the tibia. Upper end of the tibia, and it is breaching the joint as well. So there is no point keeping this tumor. You can't just scoop out everything, put bone graft here. That will not serve the purpose. So we have excised up to here. Then there is a gap. What do? Then you excise the lower end of the femur also. Bring these two cut bones together and fix it with a nail through and through. This nail is from hip to the ankle and it is fixing the knee joint. There is no knee joint. This knee joint is fused. So patient will not have a functioning knee, but patient will not have a tumor. Patient will not have a discomfort of having a tumor, pain and other problems later on in life. Only problem will be patient's knee is not there. This was olden days. Nowadays, this is called an Enneking's surgery. Resection arthrodesis or Enneking's procedure. This is for historical importance. Nowadays, we are not doing this surgery because we want to restore the functioning knee joint. So how do you do once you reset this? How do you get a functioning knee joint? We have a solution for that. That is custom made prosthesis. So we make a knee joint possible with prosthesis. So this is the prosthesis which goes into the femur, and this is the prosthesis which goes into the tibia. So once you excise the tumor and put in these prostheses, then you have a functioning knee. So with one surgery, you have eliminated the tumor from the body and you have given a functioning joint, especially the knee joint, the major joint. So this is the latest thing which we are offering to the patients. So what are the complications of GCT? So recurrence is very, very high. So you should not think that just because you have operated, recurrence will not be there. So always tell the patient that I have done my duty. Say 90% of the patients will not have recurrence. So you should count yourself that you will be in that 90%. So don't think that pessimistic and you will be in the 10%. Never ever give guarantees 100%. For that matter, in medicine, nothing is guaranteed. 2 plus 2 will never be 4. If you know that 2 plus 2 will be 4, you better be in engineering rather than being a doctor. So same amount of medicine will not cure all patients. So treatment, as I told you before, it is a tailor-made thing. So tell the patient that this is not the absolute that you are not going to get it back. But I did my best and you do your best. So it will not recur. And rarely it metastasizes to the lung. So even before you put your knife, you take all the investigations, all the scans to see whether it has gone to lungs or not. So this is about GCT. So this is how your handshake looks to a radiologist. So when you are shaking hands and if you take an X-ray, it will be similar. So you can see the watch on your girlfriend's hand, and usually we don't usually carry watches, we don't wear them. So this is about GCT, how it presents, the importance of knowing about the E's. So epiphyseal, eccentric, expansile, encapsulated, eggshell. And now end. Thank you.